तो बहुत अच्छी बात है। आज के हमारे स्पीकर भी डॉक्टर आकाश हैं, वन एंड ओनली रुमेटोलॉजिस्ट इन द सिटी। बहुत अच्छा टॉपिक होने वाला है। तो हम लोग बिफोर ये पहले साइंटिफिक सेशन शुरू करें उससे पहले एक बार प्लीज डॉक्टर्स प्रेयर के लिए खड़े हो जाइए। सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामयाः, सर्वे भद्राणि पश्यन्तु, मा कश्चित् भाग्भवेत्। तो हम न काम्य राज्यं, न सर्वं न पुनर्भवं, काम्य दुर्दात्तानां, प्राणिनां आत्मनाशम्। Please be seated. Thank you.
Good morning, everyone. It's my pleasure to welcome you all to this 10th morning CME. Today's topic is demystifying vasculitis. Demystifying vasculitis is extremely relevant today, day-to-day clinical practice. Vasculitis, often fever, weight loss, rash, neuropathy, and neural or pulmonary involvement, and is therefore frequently missed or diagnosed very late. Early recognition can be truly life-saving, as timely treatment can prevent irreversible organ damage. It's my pleasure to welcome our esteemed speaker for today's CME. We are delighted to have with us Dr. Akash Singh, a dynamic and academically brilliant rheumatologist and clinical immunologist. Dr. Akash Singh has completed his DM in clinical immunology and rheumatology from PGI Chandigarh. After MD in internal medicine from Jigmar, Puducherry. He is currently director and co-founder of Record Clinics and Pro Health Super Specialty Clinic and consultant rheumatologist at City Hospital, Gorakhpur. He has an impressive academic record with multiple national and international publications, prestigious awards including Best Paper Awards and Plenary Oral Presentation at ULAD 2024, Vienna. He is also known as National Quiz Winner and an excellent orator with a special ability to simplify complex topics. Today he will be enlightening us on the topic demystifying vasculitis. Please welcome with a huge round of applause.
This is how the vasculitis has been classified. Large vessel vasculitis, medium vessel vasculitis and small vessel vasculitis. That's like a very basic classification done in 2012. It is known as Chapel-Hill classification. There have been multiple amendments to that, but it's a very basic to start with. So I will be proceeding with 3 case scenarios, one of small vessel, then medium vessel and large vessel, and then we'll go to the classification and clinical features, and we'll end with that. So let us start. So we have a 26-year-old female presented with heel and ankle pain fever for 1 day, and in July 2022 took basic NSAIDs, no improvement, referred to rheumatology. This was the investigation, nearly unremarkable, and diagnosed as reactive arthritis, given NSAIDs, again no improvement. This patient had one particular problem of anemia. She had easy fatiguability and the HB was gradually decreasing. For this she had 2 episodes of syncope and this heel pain was there. So she was admitted under clinical hematology and medical oncology, that is what CHMO stands for anemia, and she was worked up. So HB was, you can see it has dropped from 12 to 5.6. Now that is actually concerning. Without any overt source of bleeding, no black stools, no hemoptysis, no blood anywhere else. So they had worked up, it was iron deficiency anemia, and the UGI was done, there were erosions and bone marrow biopsy also suggested iron deficiency anemia. So she was given some Paxil transfusion and discharged with a diagnosis of IDA tenosynovitis. Now this is a very common scenario. I'm sure all of us have encountered iron deficiency anemia in a clinical practice. Then she had a recurrence of this pain. The pain became more severe in October 2022. Although the early morning stiffness was less than 30 minutes, it was additive pain, easy fatigability worsened, and then came this petechial lesions over bilateral lower limbs without any abdominal pain or no bleeding manifestation, no hematuria or decreased urine output. So this were those lesions which we can see. Now this is very classical of palpable purpura, which is synonymous with small vessel vasculitis. So on general examination she was fairly okay, nothing much here. And systemic examination also was fairly okay, no organomegaly. Nothing much on examination. She had few tender joints and swollen joints. Clinically synovitis was there. And these were her investigation trend. So as you can see, it had progressively dropped up till here. You can see the CRP was quite high, 29. Remaining other things are unremarkable. Ferritin is also nearly normal. ESR and CRP were quite high. These were the only clues. And PLC had been on the increasing trend. Now, most of us would have considered this as probably some ongoing infection, but patient didn't have any history of fever. So, first understanding is raised TLC is not always sepsis, not always infection. So, then we went ahead with some advanced markers. So, viral was heavy core was positive, again not much of significance, 24-hour urine protein was normal. ANA, anti-DSDNA, anti-GPM, DCT, ROLA, all were negative. This was positive, which I have hidden for now. Then we went ahead and did the skin biopsy and CCT chest abdomen. So I'll show the biopsy image. First with the CT abdomen. So here we can see some basic hazy opacity, because obviously there was unknown source of blood loss, so we wanted to rule out occult sources like diffuse alveolar hemorrhage, and to our surprise we did see some opacities, as we can see here. And further on. So this was the abdominal image. Here we can appreciate this infarcts. These are renal infarcts. As you can see, wedge-shaped, broad-based infarcts. Now this was very eye-opening for all of us, right here. And here also you can appreciate in the coronal section. This is the skin biopsy. The resolution is not very good, but this is leukocytoplastic vasculitis, which is very classical of small vessel vasculitis. So her PR3 levels are more than 200. This is a final diagnosis of small vessel vasculitis, also known as ANCA vasculitis, which has been classified into 3 GPA, earlier known as Wegener's granulomatosis. So this is granulomatosis polyangiitis with diffuse alveolar hemorrhage, renal infarct, polyarthritis, skin involvement in leukocytoplastic vasculitis, and PR3 positive disease. So this was the first case. Now coming to the second case, this female, 50-year-old female with joint pain for 1 year, tingling numbness for 2 months, bluish discoloration of the fingers for 2 months, followed by brachial discoloration for 15 days, oral ulcers in 15 days, and fever since 5 days. So with this she presented, and large was in small joints, joint swelling was there, stiffness was there, again additive and symmetrical. Here the stiffness was more than 1.5 hours, so this was more inflammatory in nature. And she developed pallor, and then there was Raynaud's basically. And she developed numbness, buttonhole sensation, and difficulty in walking, gripping footwear. Now she had slipping of footwear. So most of us would have thought of neuropathy. Now neuropathy, obviously we need to rule out vasculitis, it's a very common cause. So then she developed this gangrene. Now gangrene is a hallmark of medium vessel vasculitis, and other causes apart from sepsis also needs to be considered. She had photosensitivity, oral ulcer, dryness, and she had mild fever. So the examination, her right radial pulse was not palpable. Now that's a very routine thing which I think at least I used to miss earlier, but I have picked up now that we must palpate the radial pulse whenever possible. ABPI was 0.6, now that is quite critical. And she had pallor, and she had dental caries, and so the gangrene of the right and left index finger, middle and ring fingers. These are the clinical photographs. So I'm sure all of us, mostly surgeons, would have encountered such cases presenting with this, and they might have thought of vascular insufficiency. But we need to understand this concept, why does vascular insufficiency occur? So vasculitis is the common cause, and vasculopathy is another cause. That difference I will discuss later. So these were the images in her toes and fingers. She had gangrene. Other examination was unremarkable. She had loss of power, like some sort of subtotal foot drop. The dorsiflexors and plantar flexors were also weak. And she had decreased fine touch to root touch. So both large fibers, small fibers were involved. Proprioception was impaired. Other examination was nearly normal. Again, we can see there has been a slight increase in the WBC count. Now, not all WBC increases sepsis. And another remarkable thing which we can see here is thrombocytosis. Now, this is likely to happen because of inflammation, because the markers increase tremendously, and that causes inflammatory thrombocytosis. It's a reactionary phenomenon. ESR again is elevated, and RFT has been diminished. So there is renal involvement here as well. Slightly OTPT derangement, and albumin is also on the lower side, with CRP again skyrocketing. So one understanding would be if anybody is having unexplained, persistently very high levels of ESR CRP, vasculitis should be considered. 24-hour urine protein was almost 1 gram. Autoimmune workup was ANA 1+, APLA negative. Again here if you see RF 356, C3, C4, viral marker negative. So with these investigations, anybody would have easily labeled her as rheumatoid arthritis. Although with rheumatoid arthritis also we have secondary vasculitis common, but that was not the case here. So we went ahead and did skyrocketing negative, IgG level normal, eco normal, SPF normal, prop, ProBNP normal, seating up nothing much. NCS had sensory motor axonal polyneuropathy. Anemia was also more in favor of inflammatory pattern. Then the doctor showed a biphasic flow and CT angio also confirmed it, and USG parotid showed some hypoechoication. Again, like in institutional biopsy were quite common, so we went ahead and did a nerve biopsy and kidney biopsy. The photo that we showing now. So this is basically the nerve, and this is the vasa nervosum. And if I'm not sure if you guys, if anybody can differentiate, but this black thing, this is the internal elastic media, which has been stained with the VH stain. And here you can see there is a break in this part. So break in internal elastic lamina is a hallmark of vasculitis. Similarly, here we can see this has the resolution again is not very great. Sorry for that. So this is the Mosen Fontana stain in which we can see reduced nerve fiber density. This is normally like all this pink should have been there throughout. But this is the pedicurium, which is the nerve fiber density decreased. Same thing here as well. This is the kidney biopsy. Here we can see dysentery glomerulonephritis. These are the crescents. This is the crescent. So we had polyarthritis, Raynaud, Sika, gangrene, large and fine fiber polyneuropathy with paucine dysentery glomerulonephritis. Now biopsy showing heel vasculitis. Again, the PR3 in this case was quite high. And again, it was diagnosed as ANCA vasculitis, but the difference here with the first case was a purely small vessel vasculitis. This was the overlap of large and small vessel. So again, vasculitis are not watertight compartment. Small, large and medium vessels can get overlap involved, as in this case. Now coming to the last case, so this is a 26-year-old female, 3 years history, hypertensive. She had continuous right side jaw pain. For this, she had visited almost 3 dentists, multiple neurologists, and a lot of other specialties as well. Now the pain begins, and she was diagnosed with TM joint investigation which was normal. Then MRI was done, which showed some apparent loops of glossophalangeal neuralgia was diagnosis. But the pain became so severe that she could not chew her food. And on just a very simple carotid palpation, there was a thrill. And other investigations normal, again which we can see CRP was elevated. And since this patient could afford, although this thrill itself is pathognomic, but still since the patient could afford, we went ahead and did this CT angio. And as also you can see very well, this stenosis which can be very well appreciated in the carotid here and other multiple areas as well. She had renal bruit. So this was a case of Takayasu arthritis type 5, and this was managed with immunomodulation. So learning points, jaw claudication is a common feature. BP should ideally be measured in both the upper limb and young females with hypertension. Age less than 40, hypertensive female, it is Takayasu unless ruled otherwise. Radial pulse we should palpate. And I have personally missed at least 3 cases I remember in my training because of just non-specific symptoms, just fatigue, malaise, nothing. And you just put your hand on the radial pulse and you find it missing. So that is a practice which I have learned. And clinical auscultation of a bruit, carotid bruit, subclavian bruit, or renal bruit is nearly pathognomic. And yeah, vasculitis, it is written in a book called as Rheumatology Secrets. Any multi-system illness lasting for more than 1 month is vasculitis, unless proven otherwise. So this is how I said the classification: small vessel, medium, large vessel. We'll go into a few details. Like large vessel, we have Takayasu arthritis, giant cell arthritis. Medium vessel, we have polyarthritis nodosa. Again, a very commonly misdiagnosis. I'll be talking slightly about the classification criteria. And Kawasaki is mostly seen in children. Small vessel vasculitis is divided into 2. ANCA vasculitis, which is again GPA, which was earlier known as Wegener's. Then we have EGPA, which was known as Strauss, and we have MPA, microscopic polyangiitis. And immune complex mediated vasculitis, in which we have IgA vasculitis, mostly involving the young children. Then we have trigonic vasculitis, urticarial vasculitis, leukocytoplastic vasculitis. And not to be missed here, variable vessel vasculitis, in which we have Behçet syndrome, we have Cogan's disease, and other secondary vasculitis in cases of lupus, rheumatoid arthritis, and relapsing polychondritis. So this is by one of my friends, Mithu. He is in the United States, so this is a lineage from him. So this is a very basic old classification, but it's very important for our understanding. So giant cell arteritis, anybody more than 50 years, now before I will proceed, I want to say these are all classification criteria, these are not diagnostic criteria. Now there is a very important difference between classification and diagnostic, that these were designed for trials, so that there can be homogeneous population in whatever clinical trials have been done. But irrevocably these are used for diagnosis. Although the classical teaching is it should not be used for diagnosis, the diagnosis has to be clinical and based on the patient, but somehow we just can't stop ourselves from using that. So giant cell arteritis, anybody more than 50 years, new headache, temporal artery abnormalities like tenderness to palpation, decreased pulsation, elevated ESR, and obviously if you do a biopsy you will find gallbladder inflammation. So any more than 3 out of these 5 would classify as giant cell arteritis. Takayasu arteritis. So this is the old classification, the new one, which will focus on this. Less than 40 years, claudication pain, decreased ABPI, systolic pressure difference more than this is more than 10 mmHg between the arms, subclavian groove, or any abnormal arteriogram finding, which I had shown earlier. Now polyarteritis nodosa. See, this is quite commonly missed. All of us have come across this constellation of symptoms. Weight loss more than 4 kg, livedoreticularis, rash, this is a skin rash. I'll be showing the photo. Testicular pain. Now this is very specific for polyarteritis nodosa. Young male presenting with testicular pain, this needs to be considered. Mononeuropathy or polyneuropathy, diastolic blood pressure, hypertension, diagnosed hypertension, or DBP more than 90 mmHg, deranged RFT, hepatitis B virus. Now again a very common thing which I am sure all of us are screening in a routine practice. This has a very strong and known association with polyarteritis nodosa. And your arteriographic abnormality obviously and biopsy will obviously prove it. Now we have a ULAR classification, not very commonly used. This was the ACR which was more in favor. Kawasaki disease mostly for the pediatric specialties, that fever for 5 days, is there any peripheral extremities or perineal area changes, polymorphous exanthema, bilateral conjunctival injection, strawberry tongue, as all of us classically have read, and cervical lymphadenopathy. Now coming up to this GPA which I had classified, this has a scoring system actually. This has not come out well, I'm sorry for that. Score more than here, it is nasal involvement, bloody discharge +3, cartilaginous involvement +2, hearing loss. Hearing loss is very common, which we must consider vasculitis, especially if it is sensorineural hearing loss. It has a +1 score. PR3 positive has a +5 score, which alone is enough to classify this as small vessel vasculitis. Anybody having eosinophilia has a -4 score. And pulmonary nodules, granuloma, and pauci-immune glomerulonephritis on biopsy. Similarly, for microscopic polyangiitis, we have -3 if there is nasal symptom. Somebody is having nasal symptom, it would classify as GPA, not MPA. And +6 if anybody has a positive NPO scoring. And similarly for EGPA, we need a score of more than 6 to classify. History of asthma, nasal polyp, pneumonitis multiplex. IgA vasculitis, I'm sure all of us would have come across this. Palpable purpura, young male, mostly bowel angina, and again biopsy will help us. Few vasculitis do not have a classical criteria yet. Behçet's disease, again a very commonly missed thing. Recurrent genital ulcer, recurrent oral ulcer, at least more than 3 times in a month. Skin lesion, this is very common. Patient will say कि डॉक्टर साहब जहाँ पे सुई चुभती है उधर दाना हो जाता है. So that we need to think about Behçet's. Hogan will have interstitial keratitis, hearing loss, single organ vasculitis, and secondary vasculitis. These are the photos of. These are all vasculitic lesions. Cutaneous findings. These are vesicles, pustules, superficial ulceration, even deep ulceration. Deep conduct ulcers will also qualify for vasculitis. Obviously, the secondary causes like diabetes and other obvious infection needs to be ruled out. They have to be considered primarily. But once we have ruled out that patient is not responding, vasculitis needs to figure out in the differential list. The classical photo of confluent purpura in cryoglobulic vasculitis. So mostly this comes to our derma colleagues, and my wife is a dermatologist, so I'm lucky in that way. So the age group, mostly it is 1:1 in the male and female. Specifically, if we see here, Takayasu has a strong predilection for female. Female to male ratio is almost 9:1. GCA, female to male is 3. So large vessel vasculitis mostly involves the female, otherwise it is almost equal. Behçet has slight again in favor of female, and this was famously for the silk. Takayasu, few things I want to focus because this is, I have at least in Gorakhpur diagnosed almost obviously in health with our cardiologist, nearly 25 patients in the last 1 year. So these things we need to definitely look out for. Unequal blood pressure in the arm, hypertension, unexplained. We need to measure blood pressure in both the arms, scalpel diarrhea, aortic regurgitation. These are vascular findings. They can be as non-specific as symptoms like lightheadedness, visual abnormality, stroke. Musculoskeletal symptom. Now this is a very common thing, chest wall pain. Patient keeps on going ECG, echo normal, some patient even land up with coronary angiography normal. They turn out to have some sort of, initially we need to consider costochondritis and encephalitis if it's not a classical anginal pain. But yeah, even in Takayasu it can have chest wall pain, joint pain, myalgia, constitutional symptoms like fever, weight loss. And obviously if there is unexplained aortic regurgitation, angina and congestive heart failure, Takayasu needs to figure out, especially if the patient is young and if she is female. Now this is a friend of giant cell arteritis, polymyalgia rheumatica. Now if you see this, almost all of us would have come across, I just read it out. Age more than 50 years, bilateral aching and stiffness 1 month or more involving the following areas: neck, shoulder, proximal arms, hips or proximal thighs. ESR more than 40 and exclusion of all diagnosis except GCA. So I'm sure all of us have encountered such patients more than 50 years, ESR slightly elevated and having neck pain, back pain, proximal thigh pain. GCA, PMR is an important entity in these patients need to consider this. Now there is CNS vasculitis as well, which we see most commonly strokes being managed conservatively. All strokes are not embolic or thrombotic. This needs to be also considered. Any of the disease which we have spoken about can cause vasculitis. Other things like APLA, TTP, syndromes like CADASIL, these are obviously rare diagnoses, but we need to at least think young strokes, obviously this needs to be considered upfront. Malignancies can cause vasospasm, these are reversible, RCVS. Reversible cerebral vasoconstrictive syndrome, the patient can totally recover. So this can have a very strong impact on the prognosis. Drugs, sarcoidosis, neurosarcoidosis is quite common, it is treatable. Infections obviously needs to be ruled out, and these are degenerative pathologies. So last slide is on this, that everything is not vasculitis. So we need to be aware of the vasculitis mimics as well. So we have like hemorrhage, scurvy can cause, ITP can cause, APLA is a very strong vasculitis mimic. Now here I would just like to go to the first slide where I showed a vessel wall. We can do that. Yeah, right here. So as you can see, vasculitis basically is when the vessel wall is involved. This we need to understand. Vasculopathy is when the lumen is involved. Now vasculopathy is a bland disease. It does not have an inflammatory component like APLA or thrombotic disorders. But vasculitis, the entire vessel wall, vasa, vasorum, vasa nervosum, all of these are involved. So basically here the pathology is progressing from the wall to the lumen, outside in pathology. And whereas vasculopathy is just restricted to the lumen, there is no wall involvement. So this is a very important point all of us need to understand. APLA is purely vasculopathy. And vasculitis is when any of the large vessel or the tunica externa, tunica adventitia for the medium vessel and tunica intima, when these vessel supplying the blood vessel, vasa, vasorum, vasa nervosum, and they get involved, the pathology starts here, and that is when the vasculitis starts. Thank you. I'll be happy to take questions.
So questions बहुत होंगे मुझे लगता है, लेकिन before we see the quiz के लिए मैं चाहूँगा डॉक्टर शैलिन सर
चूज करने के लिए।
तो क्विज का पैटर्न हमारा यही होगा. फर्स्ट क्वेश्चन विल बी फ्रॉम दिस साइड, सेकंड क्वेश्चन विल बी फ्रॉम माय राइट साइड. तो जो भी जानते हैं हैंड रेज करेंगे. डॉक्टर शैलिन सर विल सेलेक्ट हु विल आंसर, एंड वी हैव अ वेरी सरप्राइजिंग गिफ्ट्स फॉर द क्विज विनर्स एज यूजुअल. So the question is, which is medium vessel vasculitis from this side? Polyarthritis nodosa, Takayasu, GP, or is it Dechex? Just raise your hand. Sir will select the who will answer. Doctor.
Takayasu B. Wrong.
Polyarthritis. Just this side. Doctor Shahi. Polyarthritis nodosa is the right answer. Big round of applause for Dr. Shahi.
as we discussed the vasculitis classification, large vessel was Takayasu, giant cell arteritis, medium vessel was polyarteritis nodosa, Kawasaki, and then small vessel we have antrovasculitis and immune complex. So this was the basic question on classification.
Okay, so next question will be from this side. Gangrene is hallmark of which vasculitis? Large vessel, medium vessel, small vessel,
Variable vessel.
variable vessel. Just raise your hand. Sir.
Small vessel.
Wrong.
Small vessel.
Sorry, medium.
Dr. Sanjeev? Dr. Sanjeev? Medium vessel, are you sure? Medium vessel vasculitis? Yeah. So medium vessel vasculitis is the right answer. Big round of applause for Dr. Sanjeev. Okay.
Yeah, this was regarding the second case which I discussed. So, and I had emphasized also that gangrene is a hallmark of medium vessel vasculitis.
इतना फास्ट बोले सब सर ऊपर से
So, this question will be from this side. False regarding giant cell arthritis. Headache, ESR more than 50, age less than 50, abnormal artery biopsy finding this. Try your luck, sir.
ESR more than 50.
ESR more than 50 is not the right answer, sorry. We'll take another option, sir. Dr. Ashok, sir. B? C? Abnormal artery biopsy finding is not the right answer, sir. I'm really sorry, sir. आपका दूसरा कोई और लगता है डॉक्टर ओमकार headache is not the right answer. Age less than 50, that is the right answer. Big round of applause for Dr. Agrawal.
So, this was very classical. The difference between Takayasu and giant cells. Takayasu occurs in younger population, less than 40, and giant cell has to be in the elder, more than 50, not less than 50.
Very nice. So, fourth question.
एक आध लेक्चर और लेना पड़ेगा आपको
हाँ नहीं ये बिल्कुल ready रहते हैं. So this will be from this side. False regarding polyarthritis nodosa. Vestibular pain, libido-reticular gastric blood pressure more than 100, or is it hepatitis B virus positive? Just raise your hand. Just raise your hand. Dr. Shahi. Hepatitis B virus positive? Hepatitis B में commonly मिलता है. Dr. Rita. Third, gastric blood pressure more than 100. Sure. That is the right answer. More than 90 or more than 100 is false regarding polyarthritis. So that is the right answer. Totally. So last question will be can be answered from both the sides. False regarding Kawasaki. Fever for more than 5 days, frogging tongue, unilateral conjunctival injection, cervical lymphadenopathy. Sir. Unilateral conjunctival injection. Dr. Narish Agrawal sir ने सही आंसर किया है. अभी डॉक्टर प्रकाश सर. Unilateral conjunctival injection. Answer from.
सही आंसर क्या मैंने भी क्या रेस्ट किया
क्वेश्चन हाँ पीडियाट्रिशियन के लिए था. बताएं और.
Kawasaki वो criteria में देखा उसमें it is bilateral conjunctival injection remaining.
Thank you everyone. Quiz अब question answer के लिए.
No complimentary question for us. And because the following is not an immune complex associated vasculitis. Cryo. Second one. That's it. Yes. So immune complex में यही तीन थे, IgA, cryo, anti-GPM, and this is variable vessel vasculitis, Behçet's and Kogen. ये दो variable vessel vasculitis में है. And which vasculitis related to silk root?
Which was?
Yeah,
नहीं थोड़ा सा नहीं पर ज़्यादा
yes, Behçet's.
आज तो लगा 10 मिनट में
और starting में भी दो
आते अभी भी मतलब 5-10-15 मिनट
Variable vessel vasculitis इसमें Kogen है. And pathognomic of vasculitis. This we had discussed.
CTAGO, CTAGO.
Job.
Job particular.
Rudy.
Rui.
Yes, exactly. We had heard it.
So we'll take the question and answers from the audience. Any questions?
प्रकाश वैस्कुलोपैथी एंड वैस्कुलाइटिस में डिफरेंस कैसे कर रहे हैं? जैसे जैसे ओल्ड एज बढ़ रही है तो एथेरोस्क्लेरोटिक बहुत तेज बढ़ रही है.
Yes,
आप लोगों के पास ज्यादा वही पेशेंट्स आते हैं एथेरोस्क्लेरोटिक. तो हमें यदि मोर देन 50 ईयर का पेशेंट है तो कैसे डिफरेंशिएट करें क्लिनिकली कि पेशेंट है वैस्कुलाइटिक और एथेरोस्क्लेरोटिक डिजीज?
वही सर, जैसे मैंने क्लिनिकल फीचर्स बताए, तो जो कॉन्स्टिलेशन होता है, जैसे सपोज कोई पेशेंट आया, ही हैविंग मतलब सपोज एथेरोस्क्लेरोटिक डिजीज मोर देन 50, बट अगर उसको फुट ड्रॉप हो गया, कोई स्किन रैश आ गई, या ही इज हैविंग हेमोप्टाइसिस, ब्लीडिंग, लंग्स में भी कुछ, जैसे जीपीएम में इट इज अ वेरी कॉमन कॉज एंटरवेस्कुलाइटिस, जो वेगनर्स पहले कहते थे. कैविटेटिंग नोड्यूल्स जो हमें सीटी टेस्ट में मिलते हैं, मोस्ट ऑफ द टाइम इट मींस लंग एब्सेस, निमोनिया, but any pneumonia unresolving for more than 14 days, vasculitis needs to be considered. Most commonly MPA और GPA में lung involvement होता है. तो एक clinical feature देखना पड़ेगा सर कि exactly क्या है. वो वही सारा जो classification. Although I'm sorry बहुत ज़्यादा था, but I just tried to do justice to that. So foot drop, rash, disc drop, neuropathy. अगर कोई ब्रूड है, कोई आपका पल्स एब्सेंट है, या कोई ब्लूइश डिस्कलरेशन हो रहा है, गैंग्रीन हो रही है, ये सारा कुछ आ रहा है. फिर लैब में आप सीआरपी ये सब देख सकते हैं. अगर वो सब बड़ा मतलब एनीथिंग व्हिच इज नॉट एक्सप्लेन्ड, अगर एनी अनएक्सप्लेन्ड पैथोलॉजी इलनेस गोइंग फॉर मोर देन 15 डेज, इवन फैटीग एंड मैलेरिया. मैंने 3 पेशेंट मिस करे थे.
क्या?
फैटीग एंड मैलेरिया. जस्ट 3 आई हैड मिस 3 पेशेंट्स. आई वाज स्कोल्डेड वेरी बैडली बाय माय एचओडी. उसने बस राउंड में ऐसे बस सिंपल पल्स पैल्पेट किया, पल्स बता. So that pulse palpate करना जो हमें बहुत बेसिक सिखाया जाता था, that we did. मतलब I have at least inculcated that from that very day. So that will help.
कोई चीज दिमाग में जब निकल आ रही है तो वही है वैस्कुलाइटिस ही होती है.
मतलब एक बार सोच सकते हैं. इससे मैंने वैस्कुलाइटिस मिमिक कर, जैसे इन्फेक्टिव एंडोकार्डाइटिस वाज अ वेरी कॉमन चैलेंज. जैसे मेरा एनडीसीसी वाज इन्फेक्टिव एंडोकार्डाइटिस एंड डीएमसीसी वाज ऑन वैस्कुलाइटिस. तो I could somehow see कि भाई most of the times we are leaning towards infective endocarditis निकलता vasculitis है and vice versa. तो वो मिमिक वाला भी याद रखना है.
इन्फेक्टिव एंडोकार्डाइटिस बहुत कम हो गई, बहुत कम हो गई है.
यहाँ पे तो कम है, पर्टिकुलर कंडीशंस में मिल जाते हैं.
What are the signs and symptoms? Main signs and symptoms when we suspect there is vasculitis.
तो उसी पे पूरा टॉप कर रहा है. I just simplified it all of that.
इसीलिए दर्द मिल गया.
That was a very interesting question by Dr. छपड़िया. एक रिसर्च मैं को कर रहा हूँ आज के लेक्चर पर. एक बार मोहम्मद अली वर्ल्ड चैंपियन और जो मार्शल आर्ट का चैंपियन था ब्रूस ली, दोनों की लड़ाई हुई. मोहम्मद अली 200 किलो के ऊपर और ब्रूस ली 100 किलो के नीचे. मोहम्मद अली को कोई हरा दे मुश्किल था. ब्रूस ली ने उसकी आंख पर देखा, मोहम्मद अली तैयार था अटैक के लिए. तुरंत 1 मिनट बाद मोहम्मद अली जमीन पर अपने घुटने पर. ब्रूस ली ने उसका हाथ पकड़ के उठाया. डॉक्टर ने आके उससे पूछा, मोहम्मद अली तुम ठीक हो? तो मोहम्मद अली ने कहा कि नहीं, मैं रिकूप कर रहा हूँ, मेरा सांस रुक गया. एक्चुअली हुए क्या था, ब्रूस ली वाज स्टेयरिंग इन हिज आईज और उसने कब उसको अटैक किया और कब वो जमीन पर आ गया, मोहम्मद अली कुड नॉट गेस. और उसके बाद जो है मोहम्मद अली उठ के खड़ा और उसने कार में ब्रूस ली के जाने क्या करा, ब्रूस ली उठा और चला गया. तो उससे पूछा गया हुआ क्या, तो मोहम्मद अली बोला मुझे समझ तो नहीं है क्या हुआ, मैं कैसे गिरा. तो आज का लेक्चर जो है so fast, really covered very wide subject.
आपने कनेक्ट ऑडियंस भी किया
आप क्यों
आज के एपिसोड पर कर रहा हूँ। इट वाज वेरी इंटरेस्टिंग एपिसोड, मुझे याद आ गया।
काफी इंटरेस्टिंग लगा है, तो इसलिए आकाश से हम लोग रिक्वेस्ट करेंगे अगले महीने एक और सेशन एक जाइंट क्लास इसमें अलग चलेगा, तो आई थिंक दैट विल बी मोर हेल्पफुल, जिस हिसाब से लोगों का इंटरेस्ट यहाँ पे है, तो एक बार करेंगे।
वो तो जवाब तो देना।
हाँ सर, साइंस एंड सिम्टम्स सर, सबसे पहला रूमेटोलॉजी सीक्रेट एक बुक आती है, उसमें पहला लाइन लिखा हुआ है, many unexplained multi-system illness lasting for more than 30 days is vasculitis unless proven otherwise। ठीक है, अब अगर आप पैथोनॉमिक में जाएंगे सर, तो लार्ज वेसल में आपको एक स्ट्रोक मिल सकता है, यू कैन सी हार्ट फेलियर, ऑर्गन फेलियर। मीडियम वेसल में गैंग्रीन इज अ हॉलमार्क। फीवर इज अ वेरी इंपॉर्टेंट फीचर, फीवर लास्टिंग फॉर मोर देन 15 डेज, इन्फेक्शन रूल्ड आउट के बाद। एंड एंका जो स्मॉल वेसल वैस्कुलाइटिस है, तो उसमें मल्टी ऑर्गन इन्वॉल्वमेंट आपको मिलेगा, आरपीआरएफ विद लंग हेमरेज, हेमेटूरिया विद लंग हेमरेज, या आपको unexplained RPRF कोई हेमेटूरिया वगैरह नहीं आता है, you can consider polyarteritis nodosa। Proteinuria is a very common thing, all proteinuria is not because of diabetes। RBCs in urine more than 5 or 10 RBCs per hypertrophy, उसमें आपको microscopic hemeturia, उसमें vasculitis सोचना होगा। Then obviously blurring of vision, sudden visual loss, that is vasculitis। Sudden hearing loss is vasculitis। Foot drop, neuropathy which is progressive, mononeuritis multiplex, एक महीने में फुट ड्रॉप हुआ, फिर रिस्ट ड्रॉप हुआ, फिर दूसरा फुट, ऐसे रैपिडली स्किपिंग लीजन्स, ये सारा वैस्कुलाइटिस है। बेशेट्स में ऑब्वियसली रिकरेंट ओरल अल्सर्स, स्किन अल्सर्स, सारा कुछ मतलब थोड़ा सा नॉर्मल से हटके अगर कुछ है, लंबा चल रहा है, तो उसमें वैस्कुलाइटिस होना बहुत जरूरी है।
अरे इसी का हम उसको थोड़ा सा सुनाई दे रहा था। बांसुरी कब बजती है? जब थोड़ी जगह में ज्यादा हवा पास करती है तो बांसुरी बजने लगती है। बांस के झुरमुट से आवाज कब आती है? जब थोड़ी जगह में हम लोग बर्नौली थ्योरम पढ़ते थे कि अगर डायमीटर घटा दें तो स्पीड बढ़ जाती है, और जब स्पीड बढ़ी, डायमीटर घटा, तो सारे उसके मैनिफेस्टेशन आने लगे।
तो अच्छा डॉक्टर साहब ये बताइए, जैसे कुछ पेशेंट्स होते हैं कि दे वांट सम मेडिसिन्स ओनली, so if you are suspecting polyarteritis nodosa, so what common medicines you are using for those patients? At times, most of the time, patients are not going for investigation, or pretty lot many things are.
ट्रीटमेंट रह गया।
So what treatment do you, what if you suspect patient is not going for any investigation, not any workup, what common simple single medicines you prescribe for those patients if you suspect polyarteritis?
सर इस सवाल का जवाब बहुत मुश्किल है, बिकॉज वैस्कुलाइटिस में आपको इम्यूनोमॉड्यूलेशन देना है, और इम्यूनोमॉड्यूलेशन में सबसे जल्दी काम करता है स्टेरॉइड। बट अगर आपका डायग्नोसिस सपोज इन्फेक्शन निकला, या इट इज सेप्सिस, इन्फेक्टिव एंडोकार्डाइटिस, मतलब नॉन इन्फ्लेमेटरी पैथोलॉजी निकली और आपने अगर उधर स्टेरॉइड दे दिया, तो दैट विल बी अ ब्लंडर। तो इसलिए सर इसमें इतना आसान, मतलब इट्स नॉट ऐसे, मतलब वन वर्ड आंसर इसका नहीं आता।
ट्रीटमेंट रहती है, आपको भेज नहीं है।
हमारे पीजी इमरजेंसी रात के 3 बजे के पेशेंट आते हैं,
14 दिन के बाद ही देना स्टेरॉइड, पहले ट्रीटमेंट कर लो।
वंदे भारत में चाहिए, वंदे भारत। अरे उसके दो
in one in areas are medical college. Yes sir. At Shantanu, Agrawal clinics. It's very much on the main road, sir. Lotus Tower side road.
सब आप देते हैं इम्यूनोग्लोबुलिन वगैरह?
Yes ma'am. I give it totally. IV.
हमारे पास 2-3 बार कावासाकी डिजीज मैंने डायग्नोस किए थे, क्लिनिकली किया है।
उसमें कोरोनरी एम्बोलिज्म के लिए हो सकते हैं। हाँ मैम, हम देते हैं।
हमने रेफर कर दिया था उसको,
आईवीआई तो जीबीएस और कावासाकी में, इवन आजकल मायोसाइटिस में भी फर्स्ट लाइन आईवीआई हैज बीन अप्रूव्ड। एक प्रोडाउन ट्रायल करके आया था, उसमें भी नहीं मैम, एचएसटी में तो स्टेरॉइड विद, मतलब वैस्कुलाइटिस में तो देखो, अगर वैस्कुलर फर्स्ट यू हैव टू बी श्योर कि इन्फेक्शन नहीं है। आप एक बार श्योर हो गए, और वही श्योरिटी में काफी बार वी आल्सो डू अ लॉट ऑफ मिस्टेक्स, दैट इज व्हाट वी हैव लर्नड ओवर इयर्स। वंस यू आर श्योर, आपको स्टेरॉइड देना है। Now the quantum of steroid आपको कितना देना है, that depends on the organ manifestation। अभी किसी को alveolar hemorrhage हो रहा है, किसी को mononeuritis multiplex हो गया है, RPRF हो गया है, then you cannot give 1 mg per kg, you have to give a pulse dose। But अगर skin पे है, joint पे है, muscle पे है, it is not organ threatening disease, तब आप फिर 1 mg per kg दे सकते हैं। अगर minor है, जैसे सिर्फ आपका platelet थोड़ा कम हुआ है, WBC कम हुआ है, तब आप low dose दे सकते हैं। So that you have to titrate। और वो देने के बाद सबसे बड़ा रूमेटोलॉजी में चैलेंज यही है कि आप कौन सा स्टेरॉइड स्पेयरिंग एजेंट यूज करेंगे in that particular case which will benefit all the manifestation. जैसे एक manifestation का तो हमें पता है, but patients do not come with one manifestation. वो hematological के साथ आते हैं, साथ साथ renal भी है. अभी अगर उसका leukopenia है और joint pain है, then you cannot give methotrexate. Cytopenia is a contraindication. तो वो match और matching में ही सारा rheumatology का है.
प्रोकैल्सिटोनिन हेल्प करता है कि जैसे इन्फेक्शन में कंफ्यूजन हो रहा है तो किसी का
सर प्रोकैल्सिटोनिन इज अ वेरी फॉल्स रीडिंग नार्कोटिक वास्कुलाइटिस इन माय पर्सनल एक्सपीरियंस आई हैड पेशेंट ऑफ एडल्ट ऑनसेट स्टिल्स डिजीज एंड कावासाकी जिसका प्रोकैल वाज मोर देन 100 एंड आई हैड स्टिल पल्स टाइम क्योंकि उसमें आपको क्लिनिकली जाना पड़ता है प्रोकैल्सिटोनिन डजंट रियली हेल्प फॉल इन प्रोकैल्सिटोनिन आफ्टर रूलिंग आउट जैसे आपने एंकर वास्कुलाइटिस दे आर एंटी न्यूट्रोफिलिक साइटोप्लाज्मिक एसोसिएटेड एंटीबॉडी एसोसिएटेड वास्कुलाइटिस तो उसमें न्यूट्रोफिल की पैथोलॉजी है प्रोकैल्सिटोनिन भी आपका न्यूट्रोफिल ग्रैन्यूल से ही आता है so प्रोकैल्सिटोनिन per se in vasculitis is a very poor marker in other diseases like rheumatoid lupus myositis हाँ थोड़ा सा वहाँ पे आपको इन्फेक्शन के लिए हेल्प कर पाएगा पर यहाँ पे फीवर में सर ब्लड कल्चर और मैंने देखा है ब्लड कल्चर यूजुअली यहाँ पे बाय ब्रॉथ और वो सब कर रहे हैं and I do it by the most advanced BACTEC और BITEC पैनल जो आते हैं उसके लिए उसमें आपको 2 दिन के अंदर फ्लैग रिपोर्ट आ जाती है एक इंटरिम रिपोर्ट भी आ जाती है तो ब्लड कल्चर इज वेरी हेल्पफुल obviously CCD test abdomen fever lasting for more than 1 month करा ही लेते हैं सर रिपोर्ट so that will help
now it's time for the certificate presentation I request Wijahat sir please come forward to present